Hi everyone, our subject today is disruptive behavior and aggression. Basics. Disruptive and aggressive behavior are common among children from toddlerhood through adolescence. They may be transient, influenced by temperament and environmental factor, or they may be persistent, rising to the level of oppositional defiant disorder or conduct disorder, and causing significant impairment in the child's and family functioning. Oppositional defiant disorder affect 1% to 16% of children. Conduct disorder affect 1.5% to 3.4%. They can be extremely challenging to manage and, if untreated, experience an increased risk for school failure, difficulty with legal authorities, substance abuse, and ultimately underemployment as adults. Those who go on to develop conduct disorder may be dangerous to themselves and others, and in some instances require emergent treatment. Oppositional defiant disorder, ongoing symptom of negativistic, defiant, disobeyment, and hostile behavior towards authority figures. Mainly below 8 years or early adolescent, trouble with authority, breaks school rules, angry, argumentative, non-compliant, blame others for their errors, have not broken major social rule. Duration of symptom for diagnosis for at least 6 months. Conduct disorder, a repetitive and persistent pattern of behavior in which the basic rights of the others or major age-appropriate social rules are violated. Child onset below 10 years, adolescent onset more than 10 years, rarely more than 16 years. Significant aggression toward other, animal cruelty, destruction of property, theft, setting fires, law breaking, serious violation of rules, substance abuse, poor school performance, have broken major social rules, suspended from school, or have police involvement. Duration of symptom for diagnosis, more than 3 incidents within the last 12 months and at least one in the past 6 months. Features of proactive premeditated aggression: propose, obtain specific reward goals, establish social dominance, relation to angers, calculated, cold-blooded, no significant display of anger, peer relations, leadership skill and sense of humor, clinical implication and prognosis, externalized behavior, subsequent criminal behavior and common, intervention application, systematic intervention. Reactive, affective, impulsive aggression, learned behavioral response to abuse, perceptive threats, provocation in neutral, friendly situation, relationship to anger, emotionally driven, hot-blooded, visible display of anger, peer relation, peer rejection, victimization, clinical implication, common psychotic symptoms, need lithium or neuroleptic medication, intervention by cognitive behavior therapy and medication. Assessment, parent interview, child's temperament as an infant and young child, developmental history and assessment including language, detail of disturbing behavior onset, psychosocial stressor, death, separation, crisis, loss of pets at the onset, frequency, intensity, duration of an episode, triggers, trends, degree of disruption, parenting style, expectation, strategies of dealing with stress, media exposure, aggressive neighborhood. Adolescent interview, opportunity to observe, evidence of anxiety, hyperactivity, motivation for change, home, family dynamics, abuse and neglect, education, peer activities, acceptance, bullying, activities like hobbies, media use, lecture, sleep, drugs, substance abuse, depression, suicide, sexual health, sexuality, sexual activity, abuse, safety, positions of arms and vehicle driving, assessment, teacher interview, peer interview, standardized rating scales completed by teens, parents, teachers help in assessing depression, anxiety, aggression, withdrawals, inattention, hyperactivity, delinquent behavior, suicide ideation, based on other opinion used in combination with the other data. The youth self-report, child behavior checklist, direct and indirect aggression scale commonly used. Elimination, other diagnoses like mood disorder, major depression, bipolar disorder, anxiety disorder, post-traumatic stress disorder, generalized anxiety disorder, panic attack, psychotic disorder with active delusion or hallucination, substance use, active phase or withdrawal, developmental disorder, autism, mental retardation, temporal lobe epilepsy, endocrine disorder, intracranial space occupying lesion, megaloblastic anemia. Screening by pediatric symptom checklist 35 or 17, strength and difficulties questionnaire, age and stage questionnaire, social emotional, early childhood screening assessment. Conditions that may mimic or co-occurring with disruptive behavior and aggression, attention deficit hyperactive disorder. This is a common comorbidity associated of oppositional defiant disorder, and ADHD confers a poorer prognosis, and children tend to be more aggressive, have more behavior problems that are more persistent, suffer peers rejection at a higher level, and have more significant academic underachievement. Sleep deprivation. Sleep problems can cause irritability and contribute to outbursts of anger and poor impulse control. Learning problems or disability. Unidentified learning difficulties can contribute to frustration and oppositionality if disruptive or aggressive behavior is associated with problems of school performance. The child may have learning disability. Developmental problems. Children with the overall intellectual or social limitation may experience frustration and poor impulse control. Exposure to adverse childhood experience. Children who have experienced or witnessed trauma, violence, natural disaster, separation from parents, parental divorce or separation, parental substance use, neglect, or physical, emotional, or sexual abuse are at high risk of developing emotional difficulties such as adjustment disorder or post-traumatic stress disorder, and may manifest outbursts of disruptive or aggressive behavior. These possibilities should always be borne in mind because post-traumatic stress disorder requires specific trauma-focused intervention. The clinician should truthfully explore the possibilities that harsh physical or emotional punishment is related to the child's behavioral problems, or that tension might escalate to that point. Denial of trauma symptom does not mean trauma did not occur. Question about adverse childhood experience should be repeated as trusting relationship is established. Bereavement. Most children will experience the death of a family member or friend sometime in their age. Other losses may also trigger a grief response, separation or divorce of parents, relocation, change of school, deployment of a parent in a military service, a breakup with a girlfriend or boyfriend, or a remarriage of parents. Such losses are traumatic. They may result in feeling of sadness, despair, insecurity, anger, or anxiety immediately following the loss, and in some instances, more persistent anxiety or more mood problems. including post-traumatic stress disorder or depression. In some children, such losses trigger aggressive or disruptive behavior. Anxiety. Many children with disruptive or aggressive behavior have anxiety when faced with the demands that make them anxious. They use oppositional behavior or to manage their anxiety or avoid the expectation that trigger their anxiety. Depression or bipolar disorder, marked sleep disturbance, disrupted appetite, irritability, low mood, or tearfulness could indicate that a child depressed. Symptom of depression rapidly alternating with cycles of agitation may suggest bipolar mood disorder. Common symptoms of pediatric bipolar disorder include expulsive or destructive tantrums, dangerous or hypersexual behavior, aggression, irritability, bossiness with the adults, driving creativity, sometimes depicting graphic violence, excessive talking, separation anxiety, chronic depression, sleep disturbance, delusion, hallucination, psychosis, and talk of homicide or suicide. Substance use. All children exhibiting disruptive or aggressive behavior should be screened for substance use and abuse because drugs affect or withdrawal from drugs may cause irritability and reduced self-control. Autism spectrum disorder. Children with this developmental pattern also have problems with social relatedness, poor eye contact, preference for solitary activities, language often stilted, and range of interest, persistent and intense interest in a particular activity or subject. They often will have a very rigid expectation for routine or parents' promises and become anxious or angry if these expectations are not met. Protective factor. Good relationship with at least one parent, consistent parental discipline, caring relationship with the competent adult, school and family connected, pro-social peers, normal, above normal intelligence, good work habits, extracurricular activities. Clinical peers. Teens with the childhood onset of aggression are more likely to manifest delinquent activity during adolescence, persisting into adulthood compared to those with the adolescent onset. Aggression in a child at any age need to be evaluated, intervened, and not dismissed as child will grow out of it. Physical, sexual abuse children and adolescents are more likely to become seriously delinquent and violent juveniles. Child neglect in infancy is associated with the aggressive behavior in childhood. Media and aggression. Children watching violent shows are more likely to strike out at playmate, ergo, and disobey authorities and less willing to wait for things. Look for comorbid condition, especially suicide ideation. Inquire and counsel for possible abuse. Teens with the symptoms of both attention deficit hyperactivity and conduct disorder have poor outcome. Behavioral intervention are the mainstay of treatment. Effective strategies include all stakeholders in management, the teens, parents, school peers, and the community. Medication has a limited role in the management of aggression.